All right, hi everybody. So I am going to go through the exam 2 content now in this recording. So I'm just going to go through and cover all the major details for your upcoming exam. All righty, so right off the bat, we are going to just review. This content is going to be coming out of chapters 22 and 23. There are no anatomy images on the exam, so everything is multiple choice. You're going to get 67 questions, and one of them will be worth a point. The rest of them, 66 of which will be worth a point and a half. This totals up to 100 points, but you get 90 minutes to complete that, which is just about time and a half. Now, I'm going to have it set up so you have insight slides, which are summarizing major content, and then we're going to go back through afterwards. So basically, I'm giving you a glossary look at the chapter right off the bat, and then I'm coming back in later to go in and just review concepts one more time. Of course, other tools are going to be the classroom recordings and the individual chapter recordings you have to see this. To give you chapter 22 insights, we're just kind of summarizing major content with the insight slides. The first thing that we see is that we can break down the lymphatic side of the lymphatic system into the 4 major components. So the lymph, which we equivalent to plasma without proteins. The lymphatics, otherwise called lymphatic vessels, which we described information on capillaries all the way through the lymphatic ducts and address the disease of lymphedema. Additionally, the lymphatic tissues, which include 3 different types of tonsils and different types of lymphatic tissues like Malt and Galt, lymph nodes, and the concept of lymphadenopathy. Lymphatic organs to include the red bone marrow, the thymus, and the spleen. The lymphocytes themselves, we talk about how T cells, B cells, and NK cells fall under the categories of the different lymphocytes. And then we also have the different types of immunity. So this is our bridge over to the immunity side of things, where we talk about the innate immune system and the adaptive immune system. As you recall, when we come into that, we learned that there are 7 individual steps to the to the innate immune system. The adaptive immune system has the characteristics of being specific and memory-based, and we go in and learn together. We'll go back and review how the adaptive immune system is achieved by the help of B cells, and T cells. Both of them originate in the bone marrow, but B cells will go down one lineage, whereas T cells will migrate to the thymus. If interleukin 7, IL-7 is present, B cells and NK cells are produced in the bone marrow, and then if interleukin 7 is not present, the T cells will be made. In addition, looking at the insights from this chapter, you remember that we learned about different types of immunity that is achieved. So you acquire immunity over a lifetime, and it can be actively acquired when your body builds the immunity, passively acquired if someone receives donated antibodies. This is temporary immunity, it wears off as soon as the antibodies leave. Naturally acquired if the body gets naturally exposed to it, or artificially acquired if it's exposure through some kind of a medical intervention. All right, going into it a little bit further, we know that there are characteristics that we use to determine immunocompetence and define immunity. So we use the term specific, versatile, memory, and tolerant to help us understand and characterize immunity. The last part of this chapter, we went into the different types of immune responses. So starting with the use of antigen presenting cells and MHC molecules that present the antigens, they are recognized and the cell-mediated immunity starts. The cell-mediated immunity is triggered by the T cells themselves, and there's different types of T cells, 4 that we'll go through. Then the humoral antibody-mediated immunity is B cell dependent, which comes on a little bit after that initial response. We'll go through and discuss the 5 different types of antibodies that you can see listed here, the difference between a primary response versus a secondary response, the changes over a lifetime that occur with your immunity, and the impact of things like stress and aging on immunity. So these are all the different components, but going first, let's go back one more time and take a good look at the purpose or the function of the lymphatic system. So the lymphatic system can be broken down kind of into two major categories or major roles. The first thing is that it is made up of white blood cells that have to distribute themselves and serve a function in body defense. So there's the immune role, or there's the lymphatic role, which is more of maintaining the tissue balance between the blood and the tissues. And when you go back and look at things you learned even in chapter 21, you learn about how the tissues balance the amount of fluid with the help of the filtration pressures achieved. And so this is where we can talk about how the lymphatic system is very responsible for maintaining your total fluid balance. In order to get through the lymphatic system, though, you really have to look at the four components. And the four components themselves are actually better broken down for you on this table right here. So starting with the first component, lymph. This is a fluid that is just like your plasma, or even more specifically, it's just like your interstitial fluid. The thing about it is, though, the capillaries never let go of plasma proteins. And since those plasma proteins stay inside the blood, anything that filters out of it will be similar to lymph. So lymph is just like plasma minus the proteins. Any tissues that have an excess accumulation of that fluid, that actually is the condition we know of as edema. So edema is a swelling in a tissue because of excess lymph accumulation. Now, part of how the lymph is taken up from a tissue is starting with those more superficial lymphatic capillaries. Features of the capillaries, you want to remember what makes them different than the capillaries in the cardiovascular system. So key features include the fact that these guys are actually open-ended. They have small holes or slats between the cells that we term fenestration or pores, and that allows the fluid to drain into them, but then those flaps will close back up and avoid the fluid draining back out. Once the fluid enters the lymphatic capillaries, it's officially lymph. In there, it'll meet up with different types of white blood cells and begin to slowly move towards the lymphatic vessels. The vessels begin to collect, and as vessels collect towards each other, they become larger vessels that have valves to prevent backflow. Deeper, the vessels will go from superficial to deep and actually collect from the bottom part of the body in your cisterna chyli. That collects from, located in the abdomen, but it collects from the lower legs as well as your abdominal organs. Then those together work towards the thoracic duct and drain with the left side of the body into the subclavian vein, which immediately goes into the vena cava. So these guys are draining into regions of your blood flow where the resistance is low, so there's not a lot of backflow. The right lymphatic duct, though, is responsible for maintaining part of the right part of the face as well as the right upper torso and arm. And that's important just in case you're looking at lymphedema that may occur. And lymphedema itself is swelling when that vessel or node could be damaged, and that can lead to what appears to be edema but is different in terms of the cause of it. Another disorder we mentioned when we did our Kahoot, it would be lymphangiitis, which is an inflammation of the vessels, which can also occur. Okay, so the vessels come up to a variety of lymphatic tissues. So coming to lymphatic tissues, we consider the tonsils, MALT, GALT, and appendix to be the lymphatic tissues. The reason why these are considered tissues is that they're areas of concentrated white blood cells. So there's a concentrated germinative center. However, they don't have a connective tissue wrapping paper around them. What makes it go from a tissue to an organ is a more organized structure with a connective tissue barrier. Lymph nodes will actually bridge that gap because they are considered organs. Now, lymph nodes receive the flow from lymphatic vessels on the afferent side, which drains into the cortex, where you can encounter B cells and dendritic cells. As you move past the cortex in the medullary portion, that's where some T cells can be found. And together, all of these cells act like a filter. As the fluid drains from one side of the node, it'll leave out the medullary portion and go towards the efferent ductules, leaving the hilum and exiting on those efferent ductules. Now, of course, these are really great filters in the body. So if by chance you have any case where these filters get clogged up, maybe a pathogen is actually in the lymph and is trapped here, this can lead to an enlarged lymph node, and that's a condition known as lymphadenopathy. Now, all of the blood cells that we look at in the body begin their production in the bone marrow. So the bone marrow is the site for T cell, B cell, and NK cell production. So that process of lympho or lymphocytopoiesis is done in the bone marrow. However, the last two organs are responsible for storing different lymphocytes and important components of the breakdown of the lymphocytes as well. The thymus is actually the site of T cell production or T cell maturation as well. And in order to ensure that the T cells are fully mature, they are actually stored in the thymus and maintain a blood thymus barrier before they are released. Once they are mature enough, they get released into circulation, and T cells are actually circulated in the highest amount of all lymphocytes. So T cells are the ones that are circulating the body at a higher frequency than any of the other lymphocytes. Now, the last organ is the spleen, and one big thing to take away from the spleen is the spleen has two major functions. One, it helps with red blood cells and recycling red blood cells, which means it's a very, very bloody organ that receives a lot of the body's blood supply. If you put a lot of blood in an organ, it makes sense to use that organ to make sure to filter the blood. If by chance any pathogens make it into the blood, the white pulp is regions of B cells and dendritic cells, and that's where the white blood cells are found, and they can help to fight any infection. So the spleen has that very important filtration of blood function as well. Together, these lymphoid tissues and lymphoid organs are considered to be major sites for lymphoid activity because they store the different lymphocytes. The different types of lymphocytes that we've talked about include T cells, thymus-associated cells that produce their own type of immunity called cell-mediated immunity. Now, there are 4 types of T cells for you to know. The first one is a T helper cell. T helper cells are CD4 positive cells, and these guys do what their name hints, they help. T killer cells or cytotoxic T cells, TCs, these guys are CD8 positive, and they are the ones that kill any infected cells. TM cells, T memory cells, these guys are very important and very responsible for memory commission. And then TR, T regulatory cells, help to make sure that the immune system avoids overreacting. So they prevent an overreaction or too strong of an immune response. Now, T cells are one division of adaptive immunity called cell-mediated immunity. The other division of adaptive immunity is driven by B cells. B cells produce antibody-mediated immunity. Older textbooks will actually call that humoral mediated immunity because it's found in the body's humors or body's fluids. There are 2 types of B cells for you to know about. The first one is a memory B cell, and just like its name hints, it helps to store memory. The other one is a plasma B cell, and their function is to make the 5 different types of antibodies you learn about. Now, T cells and B cells are part of your adaptive immune system, but there is one other type of lymphocyte to know about, which is your NK or natural killer cells. These are performing an important function as part of your innate immunity, in which they do immune surveillance or check the IDs of other cells in the body. And so they're actually a part of your innate immunity. All of these lymphocytes together, though, really help bridge the gap into learning about the different innate factors of immunity and comparing that to adaptive immunity. So the first thing that we'll go is we'll actually look at the 7 factors of innate immunity together. First factor is going to be physical barriers. Found within those physical barriers, the first and largest barrier is your skin, but also hair. The surface of your skin has an acidic pH. Your stomach acid or your urine also utilize pH to provide a physical barrier against pathogens. There are several enzymes, for example, lysozyme, which is found in things like your tears or in your sweat or even in some of your salivary secretions, can break down the different cells. Mucus itself can trap different types of components. Then also a few other types of physical barriers include body secretions like sweat. the presence of antibodies inside the body secretion, so that IgA antibody, and even the presence of cilia along places like the respiratory tract, which will work towards moving or pushing additional pathogens out of the respiratory tract. Now, in addition to the physical barriers, the second type of innate immunity is going to be the phagocytes. Now, there are two types of phagocytes: macrophages, like the neutrophils or eosinophils that will eat or absorb something. They kind of act like cookie monsters in the human body, eating all the pathogens and picking up any of the debris. Macrophages are smaller, but macrophages are larger ones, and those can be free or fixed macrophages. Some examples include the alveolar macrophages in the lungs, or maybe the Langerhans cells in your skin, or even things like the microglia up in your brain. Then there are a set of dendritic cells, and we have specific dendritic cells that are located throughout the body, helping to provide immunity in specialized locations. Their job will be to eat anything that's pathogenic. And as it turns out, they're also going to be an important bridge. After they consume something that's a pathogen, they'll turn around and help present it to our T cells and B cells. So they serve a little bridge between the innate and adaptive immunity. All right, next one is going to be immune surveillance. Immune surveillance is done by those NK cells, or natural killer cells. They're going to float around the body in a pretty good amount of circulation, about 10 to 15% of your lymphocyte circulation, and their job is going to be to confirm on the surface of your cells that there is no hidden viral infection. Maybe if your cells have started to transform into a cancer, their job will be to kind of confirm that those cells exist and help to eliminate them if they aren't. Now, immune surveillance is step number 3. The next two on here are things that I don't need you to know too much detail about, but you want to have a general understanding about how they function. The first one is the use of interferons. Interferons are a type of molecule called a cytokine, and they serve to really let the body know that something is happening. So they act almost like a messenger, a walkie-talkie for the body to let them know if there's an infection occurring, and they work really great against viral infections. So you can actually hear about interferons because they play a pretty big role also in certain types of drug therapies. They can be used to help boost the body's immunity against different types of viral infections, or even in different types of cancer treatment. Secondary, we also have the complement. Now, complement is something that is not an actual cellular response, but it's a set of proteins that will form into the membrane of a pathogen, creating a MAC complex. So basically, they serve their function by making the MAC attack. This big complex of proteins punctures the membrane of that pathogen, and it acts like a shotgun to the pathogen, blowing a big hole in it and causing the pathogen to self-destruct. Now, those factors are the first 5 factors of innate immunity. The last 2 factors are things that very commonly have been discussed previously. The first one is inflammation. Inflammation is a concept that you learned about a long time ago, but inflammation itself triggers a set of the 4 hallmarks. The S, R, H, and P stand for swelling, redness, heat, and pain. And those triggers of inflammation happen when mast cells release histamine and heparin, the big H and H of inflammation. That triggers these reactions to occur, and then it causes an inflammatory cascade. Now, if that cascade happens, this is when you're going to expect to see a little bit of pus. Occasionally, pus can get trapped underneath the skin or underneath a layer of tissue, and that creates an abscess. Small amounts of inflammation are actually useful to infections. Large amount of inflammations can sometimes actually hinder the body's repair. Now, fevers is the 7th and final step of innate immunity, and fevers are triggered with pyrogens. Pyrogens are chemicals that light a fire in the body, and this elevated body temperature is achieved when those pyrogens act on the hypothalamus. The function of a fever is useful because it increases the body's metabolism, and it can actually literally burn off different pathogens. They can't survive the higher or elevated body temperature. Unfortunately, again, fevers can be kind of a hit or miss because fevers that are not controlled over long periods of time can lead to damage to the tissue. So it's kind of a healthy balance between the two. Innate immunity is one division of your immune system that is non-specific, and you're born with it. But over your lifetime, you will acquire the other type of immunity, adaptive or specific immunity. And specific immunity can be done by the T cells or the B cells, but the ways that you get specific immunity vary between whether or not you get it actively or passively or naturally or artificially. If you want to use examples of each, I've got them here for you. So a type of active, naturally acquired immunity would be your body getting and building immunity after you get sick from an infection. An example of active but artificially acquired would be if you intentionally injected a vaccine to build immunity against something. On the other side, passive immunity. This is going to be the type of immunity when antibodies are received. It's temporary, doesn't last forever. Well, this type can be naturally acquired through the placenta or even when a baby drinks their mother's breast milk. On the other side, you can actually utilize antibodies in a form of passive artificial immunity when you do antibody therapy. And this can be done in different types of cancer treatment or viral treatment. Together, these types of immunity achieve immunity in a specific fashion. And specific immunity has to have these 4 factors to make an immunocompetent individual. First, it has to be specific to a specific pathogen, and it has to create a memory that lasts against that specific pathogen. Other things it has to do, it has to be competent to attack many different types of pathogens, respond to many different types of pathogens, and do so well enough that it leaves the person healthy. So you utilize a bunch of different approaches to making sure that it's a versatile response. The last and one of the more important factors of immunity includes the ability to maintain tolerance to self. Tolerance to self, kind of like being nice to yourself, avoids autoimmune diseases. And we don't want the immune system to accidentally react to self tissue because this could be damaging to the person themselves. Now, immunity is not achieved overnight. It has to go through a series of steps to make those T cells and B cells active. The first set of steps are going to be when a phagocyte engulfs the pathogen and becomes an antigen-presenting cell. That antigen-presenting cell presents the antigen on the surface with the help of an MHC molecule called a major histocompatibility molecule. This is going to lead to the next step, antigen recognition. And here's when T cells really get themselves to work. T cells will be presented the antigen and they'll utilize their markers on the surface to help them identify the antigen. The first type of response usually starts with the T helper cells, where they will identify the antigen and they'll send alerts to activate both killer T cells and some B cells nearby. So those T helper cells really help boost the immune response of the other types of cells. T memory cells will also utilize this to help store and stock away memory. And one of the smartest things your adaptive immunity does is it puts memory away every time it encounters a pathogen, which boosts your total response to any type of pathogen you encounter. Now, T killer cells utilize this process to basically encourage cells to die. And their function is to encourage cells to literally cause apoptosis. There's a final division, suppressor T cells, or sometimes called regulatory T cells, that help kind of make sure nobody overreacts because you don't want to have too aggressive an immune reaction. Characteristics of the different T cells are also mentioned for you down here. But as you remember, the T helper cells started to initiate the T killer cells as well as began the connection to antibody-mediated immunity. So steps 1, 2, and 3 happen, and step 4 follows right behind. Antibody-mediated immunity is the other division of adaptive immunity, and this is because the helper T cells let the B cells know there's an antigen. And when they do so, memory B cells will stock away a little bit of memory, help boost the response next time. And plasma B cells are going to start making antibodies. And when plasma B cells start making antibodies, the characteristics of the antibodies begin to be things we're interested in. So antibodies are a Y-shaped molecule. They have a bottom portion that's constant and doesn't change. Well, one of the neatest things they can do is mix around the variable regions. These are regions at the points or the tips of the little Y, and they actually allow these antibodies to bind to 2 different antigens. Each time you change these out, the antigens can become more and more diverse, and this is why antibodies can be specific to many different factors. Now, antibodies have the 2 different antigen binding sites, but not all antibodies are the same. IgG antibodies, I can kind of think of them like the Godfather. These guys are the antibodies that do the most work in the body. They're also the ones we find in the highest amount. So they really handle a lot of your immune response. IgM antibodies, they're the ones that will come in and create an initial response, and they're very fast to respond. So we can think of them as the first responders. The IgA antibodies are found in the body's secretions. So breast milk, tears, saliva are good locations for these types of secretions. And then the IgE antibodies are very predominant and play a pretty decent role in triggering your allergic responses. Now, if these antibodies are released, the body is going to go through a primary response to an infection and then subsequently a stronger secondary response to an infection. Now, if you have this part of your immune system that you've developed over a lifetime, it didn't start off that way. In fact, you build immunity over your lifetime kind of slowly. Starting with a fetus, they actually start receiving antibodies through the placenta from their mother. They begin to be what we call immunocapable in the beginning before they're even born. However, those antibodies are really protecting them from quite a bit. When a baby is born, they're going to receive antibodies through the breast milk, and they're going to get some of those IgA antibodies. Then that baby over time is going to lose all of that passive immunity, so children have to develop their immunity. They develop it by getting vaccines or getting exposed to different pathogens. This is really strong up through puberty, but then that thymus gland is going to atrophy, and the ages through the early 20s is probably the time in which an individual makes their most significant contributions to their immunity. After about that, the immunity will decline with age, and it becomes really drastic towards the end of life, making elderly individuals more prone to infection. Different types of disorders that we know associated with the immune system. And we remember discussing lymphatic disorders previously, but disorders associated with the immune system include hypersensitivities. That's when the reactions are greater. A type of hypersensitivity, type 1, is what you might think of as a traditional allergy response. And we know that it tends to be pretty immediate, happens pretty quickly after exposure to an allergen. It can be mild from rhinitis all the way to something more severe like anaphylaxis. Other types of hypersensitivities, but slightly different, include things like autoimmune diseases. Autoimmune diseases themselves are going to be diseases where an individual's self reacts to itself, so no tolerance is built. And some examples that we gave you were type 1 diabetes or multiple sclerosis or lupus. Lastly, there's another type of disorder known as an immunodeficiency. Instead of having a hypersensitivity, this is a hyposensitivity. And this is when the immune system either doesn't form correctly. That's kind of like a primary one. An example we talked about was severe combined immune deficiency syndrome, SCIDS. Or it can even happen as a consequence of events. It could be like an infection with HIV causes AIDS, or it could be things like radiation or different types of chemotherapy that can lead to those secondary immunosuppressions. All right, everybody, that's our first look at Chapter 22, but included within this test, you also have Chapter 23. Okay, now Chapter 23 is a pretty big switch in the gears, but it relates very strongly to material you've learned thus far. So Chapter 23 and Chapter 22 are very connected to the cardiovascular system. That's why they are taught right after learning about the cardiovascular system, because it helps enhance your understanding of that system's function. Chapter 23, we learned about the 5 functions of the respiratory system. We learned about how we compare the upper versus lower and the conducting versus respiratory portions. We also learned about the important histology. So we learned about locations in the body and that specialized type of cell of epithelium we find, that pseudostratified ciliated columnar epithelium. In this one, we learned about the function of the histology as well as the anatomy to provide the body's defense in this respiratory system. And we know that at the alveoli, things get a little simpler, become simple squamous epithelium with the help of those type 1 pneumocytes. Now, this was the basics setting up the system, but then we went back through and learned about the nose, through the nasal cavity, to the pharynx, to the larynx. Then we entered the lower respiratory tract at the larynx. We learned that the larynx not just serves as a passageway for air, but also helps with the function of sound production, where we talked about phonation, the production of sound, and articulation, making sense of the sound. The larynx goes down to the trachea, to the bronchi, to the bronchioles, to the alveoli. Discussions from here, we talked about the anatomy of the lungs, discussing how it sits within the thoracic cavity in its own cavity called the pleural cavity. And we even showcased how the pleural membrane with that pleural fluid suctions and holds the lungs open. The last structures we delved into was what was happening at the alveoli. We learned how at the alveolar membrane, you've got some surfactant and a very small, very thin, half micron sized set of membranes to cross for gas exchange. Now, this is the end of the anatomy of the system, but from there we began to talk about the concept of respiration. We know that external respiration and internal respiration are paired together. External respiration is broken down into 3 portions: pulmonary ventilation, gas diffusion or exchange, and gas transport. Internal respiration is happening internally, inside the body at the tissue level, and this is because the cells themselves are breathing. So this is cellular respiration happening at the tissues. Starting with pulmonary ventilation, some of the principles we learned about included Boyle's law, the inhalation-exhalation cycles, types of breathing, muscles, factors impacting that, and volumetrics. So there's a lot here that we'll expound upon in a moment, but these are the components of just pulmonary ventilation. From there, we had gas exchange or gas diffusion, going through a couple of different gas laws, discussing how pressure gradients achieve this and the solubility of different molecules. Then we know that the cardiovascular system helps with the important function of gas transport, which included a review of hemoglobin saturation as well as the specific category of CO2 gas transport. Leaving the last type of function of this chapter to focus on the control of respiration, so how breathing is controlled locally through bronchoconstriction and bronchodilation, or the levels of the brain's control that control things from the cycles of inhalation, exhalation, the depth and the rate of breathing. And we address the different types of allergic responses and chemoreceptor, baroreceptor, stretch receptor types of reflexes achieved, and briefly discussed what apnea means, or the sensation of breathing. Now, when we looked at it, we looked at the effects on a newborn of breathing and how aging changes it, but more specifically, integrated throughout this chapter, we had some diseases that we highlighted. Discussions on lung cancer towards the end of the chapter, COPD, which include a variety of different conditions: emphysema, chronic bronchitis, shortness of breath. We even know about cystic fibrosis here. We discussed throughout this chapter asthma and how it can be exacerbated by the histamine response, and it causes a sensation of anaphylaxis. Bronchitis and bronchiolitis, we talked about how bronchoconstriction can happen and prevent that, and then the fluid accumulation. When we learn about the lung structure, we learn about the pleural fluid, but I'll mention to you pleural effusion just so you can understand that condition. Talking about the importance of the lungs volumetrics and the atmospheric pressure, we looked at pneumothorax and the collapsing of a lung, atelectasis. Apnea we discussed before because that's the sensation of breathing, but the factors at a tissue level, hypoxia or anoxia. Pneumonia happening in the lower alveoli, and even the possibility of SIDS or other types of respiratory distress syndrome. These are a variety of different diseases that are relevant to this chapter, so I've gone ahead and just highlighted them for you here. Okay, let's go though and look at respiration. Now, the anatomy side of things starts with the trach. So let's go ahead and get it going. First thing we know, guys, we have the functions of the respiratory system. The respiratory system is broken down into 5 functions. The first one, gas exchange. And gas exchange is best achieved through the fact that you have a huge surface area inside the lungs, about the size of a tennis court. The alveoli and the respiratory alveoli are the sites for gas exchange. So this is the respiratory exchange of gases. But in order to get the gases there, the process of ventilation is another function of the respiratory system. And this happens between the nose all the way to the lungs or along the conducting portion of the respiratory tract. Now, the respiratory tract is exceedingly vulnerable to pathogens. It's actually the #1 location in the body where pathogens are introduced. So protecting this system, we have a variety of important structures that are involved in protection. And we'll go through them, but we usually highlight just the key 4. The presence of hair on places like your nasal passageway, mucosa, which can trap or allow pathogens to land in it. The escalator of the cilia highway we find inside your trachea and at a few other locations in the respiratory tract that help to push pathogens out. And if by chance a pathogen makes it down into the lowest portion, alveolar macrophages are going to help support that 3rd function. Now, sound is an important one we talk about. The larynx and the oral cavity are very important components to making sure that sound can be made, produced, and interpreted. And then smell, and smell is going to be exclusively in the nasal cavity, but this might be something you might want to just review back into chapter 17, because that's where we talked about the function of that cranial nerve #1, the olfactory nerve, and how particles that you interpret as smell are trapped in your olfactory epithelium and interpreted by that olfactory nerve. The functions of the respiratory system, shown as the big 5 here, happen at different places in the respiratory system. So the entire tract itself is broken down for you on this slide. 2 ways we can look at this system. We can look at it upper versus lower tract, or we can look at it conducting versus respiratory. 2 different ways of looking at all the same organs, but this helps relate the conducting versus respiratory, helps us relate back to the first 2 functions. So the respiratory would be the function of gas exchange, and the conducting would be the function of moving the air or ventilation. The other one, the upper versus lower, is another way that the healthcare community determines how infections can be treated. Upper respiratory infections are going to happen along the nose, the nasal cavity, and even the pharynx, whereas lower respiratory infections are prone to targeting deeper in the respiratory tract. The larynx, trachea, primary bronchi to secondary bronchi, which go to tertiary bronchi, which become bronchioles. Bronchioles branch to terminal bronchioles and eventually end up as respiratory bronchioles, which will eventually produce the alveolar ducts and the various alveoli. So the tract can be looked at in a couple of different ways. Additionally, we know that the 3rd function of the respiratory tract was to defend the body against potential pathogens. So the respiratory tract has a different set of histology throughout the system. The epithelium changes throughout the tract, but there's actually a specialized type of pseudostratified ciliated columnar epithelium in the trachea, which acts like an elevator for the mucus. I kind of make jokes that it's the booger elevator, but it helps to push any trapped pathogens out of the system, and the person is encouraged to literally spit it out. Mucus itself, though, serves as a part of defense in the respiratory tract, and this is secreted by a set of cells known as goblet cells. The entire epithelium of the respiratory tract is anchored to the basement membrane and has an underlying lamina propria, which provides it with the nutrients to keep replenishing. If you go through the respiratory tract, though, and make it all the way down to the bottom of the respiratory tract, the alveoli themselves are made up of a simple squamous epithelium. And having it very, very simple is useful because this not only increases the surface area, but it also decreases the amount of distance that the gas has to pass through or exchange through. The body utilizes its unique epithelium and utilizes a few other factors to defend itself. Starting with the first factor, it actually filters the air with the help of the different hairs it encounters on the nasal cavity. Particles get trapped in the mucus. Particles are swept or pushed out of the respiratory tract because of those cilia. And worst case scenario, you have some alveolar macrophages down at the bottom to help provide that layer of defense. Now, let's go ahead and journey into the actual organs together, starting with the nose. Air is going to enter into the nasal cavity through the nares, otherwise called nostrils. The nasal septum divides it into right and left side. Once it enters the nasal cavity, the nasal conchae distribute and push the air in a turbulent fashion, which actually serves the function of moistening and humidifying the air. Now, the nasal cavity also is coated with that mucosa, so there's protection, but that mucosa actually can trap particles that can be sensed by the olfactory nerve, and so the fifth sensation of smell is actually achieved here in the nasal cavity. So our fifth function of smell we learn about in our nasal cavity. Going from the nasal cavity, there are three divisions of the pharynx. These three are connected together, and it turns out that the oropharynx and the nasopharynx are so connected that you can even make milk come out of your nose if you laugh at the same time. Like, people can experience this phenomenon, so it kind of lets you see exactly how interconnected they are. Now, these are all the components of the upper respiratory tract, which makes the larynx the dividing line to the lower respiratory tract. The lower respiratory tract with that larynx is actually starting with a strong cartilaginous model. There's three types of cartilages we learned about for the larynx: the thyroid, cricoid, and epiglottis. The thyroid creates an Adam's apple, and it sits prominently in the front, and the thyroid gland literally lands itself on top of that. The cricoid cartilage is on the posterior side, kind of providing the back side of the larynx itself. And then the epiglottis is a flap that closes on the lateral medial side, so like a sagittal flap you can see closing. And this closes upon swallowing. So the epiglottis, that flap of cartilage, once you initiate swallowing, flaps close so that you accidentally don't breathe any food or liquid into the lungs. Now, the larynx, if we look down upon it, we can actually see a structure known as the glottis, which has a series of vestibular folds. There's a set of vocal cords, which are cords of ligaments, and a set of vestibular folds, kind of like the curtains that open and close with the cords. These guys will open when air passes through, and the cords themselves will kind of shake upon that opening, which creates sound. So the fourth function of the respiratory tract is created with sound, phonation here in the larynx. Now, the process of making sense of that sound, though, comes with the oral cavity. The movement of the tongue, the opening and closing of the teeth, and the muscle gestures of the lips help articulate the sound. So total vocalizations require the larynx to produce the sound, and the articulation side requires the oral cavity to make that happen. The lower respiratory tract continues from the larynx to the trachea. The trachea is a set of cartilaginous material. It's also commonly called the windpipe. The trachea has these C-shaped cartilages, somewhere between 15 to 20 in total. People who are taller have more, people who are shorter have less. And it ends in a little V-shaped piece of cartilage called the carina. The carina serves as a branching point for the primary bronchi, and they branch actually outside of the lung tissue, so extrapulmonary branches that enter in through the lungs through the hilum or the root of the lungs. And then once they enter into the lungs, those bronchi become intrapulmonary bronchi. The right bronchi is steeper than the left bronchi, and the right bronchi is actually going to be wider in diameter because the right lung is slightly larger in size. The left bronchi is going to be more horizontal of an angle with a smaller diameter because the left lung is smaller because it has to accommodate the direction, the heart and the heart's tissue in between. Now, the primary bronchi branch to secondary bronchi, and as that happens, they begin to lose cartilage. Secondary bronchi become tertiary bronchi, and the cartilage becomes more consistent. Tertiary bronchi become bronchioles, and there's not a consistent ring of cartilage. There's a lot more smooth muscle, and bronchioles use smooth muscles to help open them up. And so bronchioles are where you're going to really bring in the concept of bronchoconstriction and bronchodilation, as those smooth muscles help to hold them open, as well as to increase or decrease diameter as needed. Those bronchioles will go eventually to terminal bronchioles. Terminal bronchioles branch into respiratory bronchioles and alveoli. And now you're in the respiratory portion of the respiratory tract. The bronchioles and the alveoli themselves have a set of capillary beds, and a great reminder for this is in chapter 21. So to remind you of the actual cardiac conduction, I don't want you to forget, we've talked about pulmonary circulation extensively before. So the capillary beds surround the alveoli. And what happens is there's a very tight connection between the simple squamous epithelium, the type 1 pneumocyte membrane, and those capillary beds, creating a very small surface area, small distance for them to exchange. The alveoli are many, many branches. I mentioned a tennis court earlier, but the alveoli themselves also have a type 2 pneumocyte inside them that produces surfactant. And surfactant is a molecule that is mostly oily, but it creates a surface tension that holds the alveoli open, keeps your alveoli from closing every time you exhale. The other thing that we find in the alveoli are those alveolar macrophages. And to avoid any type of pneumonia, those macrophages are going to surveil and make sure they try to keep those alveoli safe from inflammation or infection. Some things that we discussed, we learned about this. We did talk about developmentally how surfactant is something that develops later in the process. So a baby that's born prematurely has a link to more asthma and even SIDS risk. Respiratory distress happens for individuals that don't make enough surfactant. So that's where SIDS comes into that connection. SIDS can also be associated with the brain-lung connection not being developed in certain individuals. There's a lot of debate about the cause of it, but as the years have gone by, we do realize it's probably more of a brain-lung connection. And then one of the other disorders we talk about pretty extensively here in the alveoli would be that condition of pneumonia, which is an inflammation or an infection to the alveoli. A few other infections, though, worthy of discussion. Bronchitis or bronchiolitis are an inflammation of the bronchioles, and they can be chronic in conditions like people that have COPD because the air doesn't move and continuously stays inflamed. The way that these bronchioles control and open and close is through bronchodilation. They open, which is going to be when the sympathetic nervous system pops your lungs open, increases your gas exchange so that you can have the fight for your life. Or they constrict more due to parasympathetic innervation, and that's when you see the rest and digest, so there's no need to take as deep of breaths. Constriction and opening and closing of these airways does affect two different types of disorders. So asthma would be a condition where the airways stay too constricted, inadequate flow gets deep into the lungs. And anaphylaxis is actually an allergic condition associated with a massive amount of vasodilation bleeding into the tissues, which actually triggers the smooth muscles to close, and an individual can literally choke to death in their own lungs because those smooth muscles will constrict and close off or perform bronchoconstriction. Now, the lower respiratory tract really terminates in the fleshy tissue of the lungs. The fleshy tissue of the lungs is divided into the right and left side. The right side is larger, and the base of it actually sits on the liver. The left lung itself is smaller, and it has a visible cardiac notch to accommodate that. The right lung has 3 lobes, the left lung has 2. The blood supply to your lungs is achieved through the pulmonary circuit, but because the lungs are located very close to the heart, the total blood pressure is much lower. And so an example of a disease that's associated with that, we might talk about a pulmonary embolism. Because the pressure that exists inside the heart will still push a clot through the heart itself, they can get trapped inside the lung tissue and lead to the deadening of your lung tissue. Now, your lungs are actually found within the thoracic cavity and surrounded by a set of connective tissue known as your pleura. A membrane known as your pleura. The pleura has a parietal side, which lines the thoracic cavity, and a visceral side that lines the lung surface itself. Now, the inside between the two is a pleural fluid, and this fluid actually helps to suction or hold those two layers together, and it helps keep the lungs open. If you punctured that, that's when you get an individual with pneumothorax, which can cause lung collapse. But another disease of this worthy of mentioning to you guys includes a disease associated with inflammation of that. We call that pleurisy. And an individual can have an excess fluid called a pleural effusion. It's actually diagnosed really easily with the help of a cloudy chest x-ray for an individual. This infection of pleurisy can be treated before it gets too severe, but if it gets too severe, it could collapse a lung because the fluid itself could push that lung closed. All right, guys, the breathing side of things has been completely broken down for you into the different components, but we know that when it comes to breathing, we are looking at external versus internal respiration. External respiration includes the process of pulmonary ventilation, the movement of air, the gas exchange that's happening, or sometimes called gas diffusion, that's happening in the alveoli. Then the third component really brings in the cardiovascular system and the blood itself when the gas is transported. And then once that gas has made its way to the tissue, the internal respiration happens at the tissues. And basically you want to think about it as if your cells are breathing. And this is achieved best through the process of diffusion. Now remember, there's a lot happening in these capillary beds at the tissues. There's also filtration and reabsorption, which tie the connection over to the lymphatic system. And then the principles of diffusion are what we'll talk about pretty extensively here. So internal respiration, though, is achieved at the tissue level. We're going to talk about it here in this chapter just a little bit, but we're also going to review the importance of internal respiration when we look at things that happen over there in chapter 27. So we'll be talking about this in a few different places within your text. Now, the concepts of respiration have to start with that pulmonary ventilation. And going to the lungs, we want to make sure you're familiar with the way that pulmonary ventilation is achieved. So right off the bat, the types of breathing. The first type of breathing an individual can have is eupnea. That's just quiet, normal breathing. That's about 12 to 15 breaths per minute. And it's measured as a respiratory rate. The other type of breathing, forced breathing, is called hypernia. And this happens through active inhalation and exhalation cycles. The reason why breathing rates may change is because a tissue is hypoxic or even lacking oxygen, anoxic. And we can actually see how the different rates of ventilation are impacted and can impact things like the levels of the respiratory gases. In order for this pulmonary ventilation to start, though, guys, and I'm going to come back to this slide in just a moment, we want to start with Boyle's law. Boyle's law says that as the pressure changes, inversely proportional to the volume. So basically this, guys, as the lungs expand to inhale, the pressure on the outside of the lungs is greater than the pressure on the inside, and so the air is pushed into the lungs. Once the air is pushed into the lungs are now very filled up, and the pressure on the inside of it is going to begin to push them out. You guys want to think about a balloon releasing air, but that's why exhalation is a passive event, because it easily wants to push the air out because you have that pressure gradient. And the pressure changes up and down throughout the breathing cycle. Now, the lungs themselves are responsible for changing and breathing in and out. And you can, like I said, breathe quietly, in a condition known as eupnea. If you let your diaphragm do your breathing, you can call diaphragmatic breathing is a more deeper breathing. If you let your costules, your external intercostals, do the majority of the work, that's going to create a shallower type of breathing. Forced breathing, though, is really going to bring in a lot of those accessory muscles into the process. Now, what triggers respiratory rates to change? Why somebody might want to breathe faster or slower depends a lot on the control of breathing factors. But I'm just going to mention two of them here, and I'm going to re-mention them again later. So I know I might repeat myself, not intentionally, but I just want to make sure we make that connection as to why breathing paces change. First off, hypoventilation. A person who's not breathing very deep, or a person who's breathing only very shallow breaths and very low respiratory rate, this could be a person who has COPD, or even a person who's at the end of their life. As a consequence of that hypoventilation, they're going to end up with low amounts of oxygen in their blood and a much higher amount of CO2 in their blood. And so what we look for in patients who are suffering from issues with hypoventilation is that the pH of their blood is going to drop, and they're probably going to be acidotic. Okay, and so an individual who is suffering from this for any extended period of time, that'll impact whether they speed up or slow down their breathing. The other side of it, hyperventilation, is an elevated respiratory rate. So somebody breathing 30 respirations a minute, for example. This is oftentimes triggered by emotional distress, anxiety, things like that. And this will lead to the blood having low CO2 levels. The person will actually be slightly alkalotic. And so one of the strategies for something like this is to let them breathe into a bag. Sometimes they'll actually get very faint, and this can allow the CO2 levels to rise once they resume a deeper breath cycle. So these two types of ventilation relate back to the different types of breathing. Cessation of breathing we learn about later as apnea. Okay, guys, so pulmonary ventilation begins by looking at the factors of breathing. In fact, breathing is achieved with the help of inhaling and exhaling muscles. And inhalation muscles include the diaphragm, which is about 75% of your breathing. And this expands the abdomen outward and increases the cavity of the chest. About 25% of inhalation is also going to be the external intercostals, and they help to raise the chest and expand the thoracic cavity outward. Inhalation has to be an active choice, and so a person always has to choose to inhale because of the pressure gradient on the outside to the inside. But exhalation is a really easy thing. In fact, these muscles, once they relax, will almost encourage exhalation. If somebody wants to push exhalation, they can also use their internal intercostals or even their abdominal muscles to get the air out faster. So exhalation can be pushed actively, or it can passively happen because of that pressure gradient. Now, the breathing that an individual does has to encounter a set of resistance factors. And the fact that the lungs seek to move the air in and out, they actually battle against a measure known as compliance. The more compliant the lungs are, the better they move. The less compliant the lungs are, the more resistance there is to pulmonary ventilation. So compliance is measured with three different factors. First one is the amount of connective tissue in the lungs. If there's an extensive amount of connective tissue in the lungs can't expand as well. So conditions like cystic fibrosis or emphysema, long-term COPD, can cause connective tissue levels to rise. Another thing, the level of surfactant in the lungs. So, for example, individuals that are prematurely born or smoking 100% reduces the level of surfactant and adjusts that, reducing compliancy and poor ventilation. Now, as a side effect, though, the muscles of breathing, which we outlined for you at the start of this slide, including the muscles of inhalation and exhalation, they also play a role in how efficiently you can ventilate. Once air is brought in, though, the process of measuring that air is done through respiratory volumes. One big thing we know, males have a greater lung capacity, about 6 liters, compared to females, about 4.2 liters. And we can measure the movement of air from the lungs. Tidal volume moves the air in and out of the lungs, kind of like the waves in the ocean, the tides in the ocean. And that's about 500 mils, so about half a liter each breath. Now, this is just the movement of air that's being moved, but if chosen, you can engage those expiratory muscles, those intercostal muscles, the internal intercostals, and the abdomen, and push the air out. That creates a volume known as the expiratory reserve volume, fully exhaling. The other side of it, you can also force yourself to inspire. Take that diaphragm and the external intercostal muscles, and you can force air in. The deepest breath you can take creates something known as your inspirational reserve volume. Now, both of these volumes plus the tidal volume create your vital capacity, the amount of air you're kind of working with on a consistent basis. But there is always going to be a small amount of air left behind in the passageways of your respiratory tract, and that's known as your residual volume. And this stays inside the passageways and doesn't leave. It gets exchanged a small amount each time you take a breath, but that residual volume is part of why your lungs avoid collapsing every time you exhale. Okay, so combining that, we can actually look at an individual's capacity. If you want to force yourself to breathe in as much as you can, you're going to have to breathe in your normal tidal volume plus your inspiratory reserve volume, and that's called your inspiratory capacity. So this is the amount you can make your lungs force in. However, what we like to know about individuals is their vital capacity, and that vital capacity is the total amount of air they can move. This includes inspiration, tidal volume, and expiration. And then, like I said, we can measure a person's total lung capacity, or at least predict it, by looking at their vital capacity plus their reserve volume. Now, the problem with this is the reserve volume. In order to get rid of that, you'd have to puncture the lung to get it all to come out. So we can never truly know an individual's total capacity unless we were to puncture the lung and release that air. So what we really use a lot is the vital capacity. This is kind of what a person's working with in terms of how well their lungs can move the air. Now, moving the air is only one part. That's step one of the respiratory functions. External respiration, step one. Step two is gas exchange. The principles of gas exchange start with another law. So this one is Dalton's law. Dalton's law says that the total pressure is equal to all the partial pressures combined. And this is going to be important because we know that the air that we breathe is not just oxygen. It's a mixture of many different gases. In fact, nitrogen is the most abundant molecule in the air that we breathe. Now, thanks to the fact that Henry's law tells us that gas, when under pressure, can dissolve into liquids, depends on the solubility. And it turns out CO2 is much more soluble than nitrogen. And so the reason why you don't end up with the bends just from breathing normal air around you is because CO2 is soluble, but nitrogen is not. Now, Henry's law lets us know that gas can get trapped into liquids. In fact, that's going to be really important when it comes to how you move CO2 in the body. Now, gas exchange happens inside the lungs at the alveoli, and this is when the pressure of oxygen pushes the oxygen into the blood in the alveoli, and the CO2 leaves. So the alveoli exchange with the plasma. The oxygen goes in and the CO2 comes out. And we can measure when oxygen makes its way in with the help of oxygen saturation curves, oxygen hemoglobin saturation curves. Healthy people have good saturation. In fact, if you were to breathe in 100% oxygen, you can almost saturate up to 97.5% of your hemoglobin. That's really good saturation. But if you're not as healthy, or you have something going on, like, for example, you have a high amount of CO2, so maybe you have something like COPD, or you have an excess amount of lactic acid, and that would be measured by bisphosphoglycerate, or BPG. These two things can lower the body's pH, and low pH or high body temperatures lower your saturation. And these unhealthy conditions mean you don't transport oxygen as well as you should. The other thing to remember, though, about the affinity for oxygen is those little tiny fetal hemoglobin can have about a 4-time affinity over adult hemoglobin. This benefits the fetus tremendously, but it can harm the mother as she's carrying around that fetus. So the mother accommodates that fetal hemoglobin by increasing the mother's total blood volume. And so one of the effects on a pregnant female is she increases her total blood volume so that the fetus doesn't steal all of her oxygen. Okay, now oxygen is a gas that's transported, but another gas that's transported is CO2. And as it turns out, carbon monoxide, CO, itself can also take up the place of oxygen in your hemoglobin. And so we want to avoid carbon monoxide because it's a pretty dangerous one. In fact, a person can get carbon monoxide poisoning. Now, what we know about CO2 is that the body senses CO2 levels and it checks the pH and the CO2 of your blood often. And that's in fact why we have to look at control of respiration. But CO2 itself is transported in 3 different ways. 70%, the majority of the CO2 in your body is transported as bicarbonate. And that bicarbonate, when in excess, lowers the pH of your blood. However, the presence of it in smaller amounts acts like a baking soda buffer in your blood. So there's negatives to too much CO2 because they drop the pH of the blood, but having it at all, it's a nice buffer inside the body. So it's kind of like a catch-22. On the other side of it, 23% of your CO2 can find its way into hemoglobin and be carried as carbaminohemoglobin. Then there's a small amount, 7%, that makes you into a soda can, and you dissolve that CO2 into the plasma itself, kind of like little tiny, like a soda can that has yet to be popped. So combining it together, guys, 77% is mostly just dissolved and only 23% is transported with hemoglobin. But you need to remember that 70% in bicarbonate is going to be something we need to understand and use, because the more the CO2 enters the body, the more the acid is there. If you don't get rid of CO2, your blood will be very acidic. So you need to breathe. Now, as the CO2 levels lower, this is going to trigger the levels of neural control. And as it turns out, the neural control levels follow 3 different levels. At the base of your brainstem, your medulla oblongata involves itself in basic inhalation and exhalation. If you want to force breathing to happen, you can use both your dorsal group and your respiratory group. And your dorsal group does inhalation, your ventral group does inhalation and exhalation. However, quiet breathing, you just let your dorsal group kind of handle that. So when you're not thinking about breathing, it's your dorsal group, the one in front, that's making that happen. On the other side of things, guys, the level 2 is the pons. The pons is responsible for determining the depth and the rate of your respiration. Again, you're not in control of this, but what happens is different sensors throughout your nervous system and in your blood help to determine which one of these 2 centers to trigger. Pneumotaxis is traditionally the pacemaker of your respiration, and your apneustic center is very sensitive to the effects of the autonomic nervous system. Now, the autonomic nervous system, if I say autonomic, you say hypothalamus, is going to fall on that 3rd level of that, that 1st level, that highest order level, because that's going to control your need to breathe faster. And this is going to be sympathetic and parasympathetic activities. So we talked about bronchoconstriction, bronchodilation also running through that center. Then lastly, and this is the neat part about skeletal muscles, is you are in control. So skeletal muscles themselves help you choose to breathe and allow you to maintain a higher degree of control of everything downstream, because they can help you control whether you do or don't move the air. Now, what would trigger some of these unconsciously might be reflexes. Reflexes have major effects on the pons. And one thing, there's basically going to be 3 different types of reflexes I talked to you. First one, chemoreceptors. They're going to be found in places like your aortic or carotid bodies, or even your CSF has chemoreceptors. And like I said before, guys, you are best at sensing high CO2, low oxygen, which means you also have a low pH. And so that sensation of high CO2 called hypercapnia is triggered by hypoventilation. COPD patients, end-of-life patients. The hypocapnia, that's caused by hyperventilation. That's the emotional distress we talked about earlier. Those will trigger your reflexes, which will initiate changes to your breathing. Baroreceptors play on the fact that your lungs and part of your respiration utilizes and changes in response to blood pressure. So this is your connection to the cardiovascular system. Stretch receptors, like the Hering-Brewer receptors, also help avoid overinflating the lungs. They prevent you from popping a lung, basically. And then there is a set of protective reflexes. So chemoreceptors, baro and stretch receptors, and then lastly, protective reflexes. If a toxin or a chemical or even like accidentally inhaling dust comes into the lungs, this is going to trigger things like sneezing, coughing, and associated laryngeal spasms. Okay, guys, now the last kind of thing to look at when talking about the lungs is the effect of age. And it starts in the beginning. When a baby is first born, they're going to begin to experience during their exit of the birth canal a depression in their oxygen levels, which is going to trigger their initial desire to breathe. At birth, once that placenta, once the umbilical cord is actually cut, the pulmonary circulation is going to be completed. The alveoli themselves have some surfactant that will begin to be rapidly produced, and the alveoli will continue to expand and open within hours after birth. The baby has enough pressure, though, with that scream in the lungs, that thankfully they can snap the foramen ovale closed, creating fossa ovalis in the heart, and also kind of pushing that ductus arteriosus together, and this allows the heart to pump properly. If you need to review this, guys, go back to fetal circulation in chapter 21. If you don't have this down, if you don't understand this, go back to fetal circulation in chapter 21, because this stuff is important. But this starts off a person's life. They go through their life with a variety of other health conditions associated. And then towards the end of life, a person's aging, the biggest effects, definitely your lungs lose their elasticity. They've been exposed to lots of things over the lifetime, potentially gotten damaged over a lifetime, so more scar tissue builds up. And you guys may remember 3 factors of compliance. One of that was the connective tissue. So since this happens, it reduces compliance. There's oftentimes even arthritis between the rib cage, which will reduce the muscles compliancy. And next thing you know, a person just doesn't breathe as well as when they were younger. All right, everybody, we've done it. This is getting you out of all of the different factors associated with this chapter. So thanks. Good luck.